operational and financial management, strategic planning, healthcare policy, and human resource management. Beyond his professional practice, Dr. Eletu has been an active contributor to medical associations and NGOs. He has held leadership roles, including the National Secretary of the Pediatric Association of Nigeria and Secretary of the Faculty of Pediatrics, and the current president of the Guild of Pediatricians in Practice. Okay, he continues to serve as an examiner and accreditation team member of the Faculty of Pediatrics. He is a board member of the Marina Medical Services Limited and Canadian Consulting Limited. He is widely respected for commitment to child health, healthcare financing, and capacity building. Dr. Eletu has also co-authored research publications and facilitated health projects, including intensive care unit installations in government hospitals through RCCG medical missions. He is a mentor, a strategist, and an advocate for sustainable healthcare. He embodies excellence in service and leadership. Join me as we make a warm welcome to Dr. Olasende Eletu. Sir, your CV is great.
Thank you very much, Marizu. At some point, I was wondering who you were describing. Okay, good morning, everybody. I just want to thank the management of EHA Clinics for organizing this webinar, and on two topics that most parents probably will never imagine that will happen in children. So it's good that we're discussing this to create awareness and let everybody know where we stand. I would like to start by sharing my share. So, can you see my slides?
Yes, sir. If you will
okay,
just
thank you very much. Okay,
so
right. Correct. So the topic for today is discussing hypertension and diabetes mellitus in children. And like I said earlier, a lot of us will not imagine that children have these conditions. And I would like to start by discussing hypertension first, and then go on to talk about diabetes mellitus. So hypertension, I'm sure most of us have heard that word before. And what this basically means is the blood pressure of that child is higher than expected for the child's age, sex, and height. And just to also let us know that we usually don't use the normal adult values for children because the blood pressure changes as the child grows older in terms of age, the sex, as well as the height. So there's a variability. Therefore, we talk about hypertension in children using percentiles rather than fixed figures. And we try to define hypertension. Sorry, let me just go back. Apologies. Okay. So for the adolescents, sorry, I'm trying to remove. Okay. All right. So we try to define hypertension in children or adolescents as blood pressure, average blood pressure that is above the 95th centile for their age, for their sex, and their height when we measure this over multiple visits. So it's going to be extremely difficult to just take one measurement and then conclude that that child is hypertensive. Now, we also know that this condition is becoming more common, particularly because the high numbers of children who are obese. I will also tell you that the first case of hypertension, I mean, when I'm talking about the age, the lowest age I've ever seen a child who was hypertensive was a child that was born and started having seizures. And we did everything to find out what the cause of the seizures was. We couldn't find a cause until one of the consultants in the unit said, have we checked the blood pressure of this child? And when we did, surprisingly, it was extremely high. Of course, the child, unexpectedly died. And post-mortem, we realized that the child had a tumor that was secreting a lot of hormones that raised the blood pressure. which we couldn't really do anything about. So let's look at some basic definitions of hypertension. Blood pressure is determined by two main factors: cardiac output, which in normal definition, we talk about the contractility of the heart, and then peripheral resistance, which is how the blood flows through the vessels of the body. So as we know, the heart is a pump and it pumps blood around some vessels in the body. So blood pressure would rise when we have an increase in either cardiac output or we have increase in peripheral resistance. Also important to know that for children, most of the causes of hypertension will be as a result of cardiac output issues rather than peripheral resistance, which we see more in the adults. This is just a slide to show us, particularly for those of us who are non-medical, what we mean by it. So basically says raise pressure within the blood vessels. And most of us are used to the concept of 120/80, which means we're measuring the systolic blood pressure, which is the upper pressure, which happens when the heart contracts. And when the heart relaxes, that's when we get the diastolic blood pressure. I'm told we have a mixed audience, so that's why I'm trying to explain this. Now, going back to history, hypertension has been diagnosed as early as mankind, but the earliest use of the word in medical literature was in 1893. So we can imagine that this is a long-standing issue. How do we define blood pressure in children? Now, if you look at this slide, we've divided into children before adolescents and children who have attained the adolescent age group. So that's why we have 1 to less than 13 and 13 or greater than 13. The pressures for children who are greater than 13 will follow, so very similar to what the adult blood pressures are. But for those between the ages of 1 to 13, we usually define normal blood pressure as blood pressure less than the 95th centile for their age, weight, and sex. And we say pre-hypertension or elevated hypertension, as we call it now, when the systolic blood pressure or the diastolic blood pressure is greater than the 90th centile but lower than the 95th centile, or when the blood pressure is 120/80 or less. So, and then we now talk about stage 1 hypertension, when the systolic and diastolic blood pressures are greater than the 95th centile, or when it is less than 95th centile, and then we add 12 millimeters of mercury to whatever readings we've gotten. So if we get values up around 130/80 up to 139/89, we classify that as stage 1 hypertension. But any values higher than that will be classified as stage 2 hypertension. This is just a screening guide to show that when we see children in the clinic and they have this kind of pressure, so let's assume we're seeing a 10-year-old child and the blood pressure is about 108/72. This should tell us that we need to look further and find out why this pressure is this high, so that we may need to investigate further. Okay, this is just in graphical form to tell us what we've just discussed. Anything below the 90th centile for age, weight, and sex is normal. Anything between 90th and 95th is pre-hypertension or elevated blood pressure. Anything above the 95th centile is classified as hypertension. And this is the kind of chart we're talking about. So we can plot the blood pressure readings, both systolic and diastolic, and that tells us where this patient has fallen into. Now, when we come to the clinic for blood pressure measurements, there are two sides to the blood pressure concept. Most of us know about what we call white coat hypertension, which I'll come to shortly. But also, we also know that there's something called the accommodative effect, which is that blood pressures are usually a bit lower because there are usually variabilities when we check the blood pressure from time to time. And then over a period of time, we get used to the fact that, oh, I'm just going to have my blood pressure measured, so it's not likely to cause some form of anxiety, and then the blood pressures will be normal. Now, the white coat hypertension tells us that when we go to the clinic, the blood pressure in the clinic is usually higher compared to when we take our blood pressures at home, for instance, which is outside the clinic setting. And a lot of times this has been attributed to anxiety. But then looking back, is this really elevated blood pressure or is it not? The only way we can find out, of course, is if we now monitor these patients frequently, either checking blood pressures when they're in school, or we take readings in the morning and at night over a period of 1 week at home, or we simply do a 24-hour ambulatory blood pressure measurement where a machine is wrapped around the arm of the patient and he goes about his or her normal daily activities, and the blood pressure measurements are being taken routinely and kept in on the system, and then we have a printout later to show over the 24-hour period what the blood pressure is like. We should also not forget that there's something called masked hypertension, which happens when you go to the clinic, which is an opposite of white coat hypertension. So you're in the clinic, your blood pressure is normal, but when you get home, the blood pressure is higher. Now, for us to make a diagnosis, I guess we need to measure the blood pressure properly. So we see that there are so many ways of measuring blood pressure from what we all know when we go to the clinic, but the upper arm auscultation is the best method for measuring blood pressure, and that forms the basis for the reference. The wrist blood pressure measurement is not reliable because it's usually higher, and that's based on the concept that the further the artery is from the heart, the higher the blood pressure is likely to be. So we usually don't recommend that for children. But the ambulatory blood pressure, which I've just described, will give us the best assessment of blood pressure over a period of time. Now, how do we do it? I'm sure we've all seen this being done before, but we assume that it's been properly done. But a lot of times it may not be properly done. So this tells us that the best, when we use the stethoscope, the bell is the best site to use in getting our blood pressure. Then we inflate the cuff around the arm, and we use our finger to palpate the artery around the elbow and determine what the higher value is. And then we inflate it 20 to 30 millimeters of mercury above the radial pulse. And then we'll start deflating to ensure that we get the first Korokov sound, which is the systolic blood pressure, and when it fades, which is the diastolic blood pressure. Also very important that the size of the cuff you use will determine the result of the readings you get. So we know that as the child grows, the arm obviously will grow, and the cuff size you also use will also need to change. So what that means for us then is that for us to get the proper value, we need to use a bladder that will cover at least 80 to 100% of the arm circumference, and this is the bladder. The bladder is totally different from the cuff itself, the total cuff, because you have the cloth part of the cuff. So for you to get a proper reading, you should cover at least 80% of the arm circumference. And of course, you should also cover at least 40% of the length of the arm for you to get a proper reading. So this is a picture of what I've just described. And this is the manual sphygmomanometer. Now, the automated devices, there are so many of them available, but we don't have normal normative standards for these devices, so we rarely use them. And of course, accuracy of most of them is uncertain, but that's not to say that they are not useful, because we can also then use them as follow-up for children who've been diagnosed as hypertensive. At what stage do we start measurement? Usually at the age of 3 years for children who are healthy and okay and normal, and then we measure yearly thereafter if the blood pressure is normal. But if we see children who are obese, for instance, or children who have had kidney problems, who are diabetic, who have had history of congenital heart problems, then we should measure their blood pressures before the age of 3 years. Also, another group of children that we need to worry about are the premature babies and then children with sickle cell disease, which also predisposes them to raised blood pressure. Classification. So we see a child who is hypertensive. We need to determine whether this is what we call a primary hypertension or secondary. Primary in the sense that we've done all the investigations, we can't find any cause. And secondary, when we're able to identify a cause of the blood pressure that is elevated. And the commonest causes will be kidney-related issues, heart-related issues, particularly congenital malformations, some endocrine problems, like I described in the newborn baby that I said is a case I've seen, and then some drugs that we use. Now, non-steroidal anti-inflammatory drugs are something we use a lot in managing pain and fever. But let us realize that prolonged use can predispose to hypertension. And then some of the drugs, nasal drops and cough syrups that we also use. And patients who have sleep apnea, when they have obstructive episodes during sleep, they are also liable to have hypertension, particularly if it's been going on for a long time. What are the risk factors? Obesity, family history of high blood pressure, family history of diabetes or high cholesterol, excessive salt intake, sedentary life where the children don't move around as much, or they sit behind the screen and watch TV and eat, which will predispose to obesity, exposure to smoke, being of the black race carries a higher risk, and of course, being a male. So when we evaluate the children, what are we looking out for? First is we need to identify whether we're dealing with primary hypertension or secondary hypertension. And if we're dealing with primary hypertension, of course, like I said, it means we've done all the tests, we can't find anything wrong. So the management will be slightly different from those who have secondary hypertension. And even for those who have primary hypertension, we need to look out for predisposing factors like I've just mentioned: diabetes, obesity, family history, fat metabolism disorders. And we also need to identify the patients in which we need to start therapy. So if a child has secondary hypertension or has hypertension that's associated with other problems, for instance, kidney-related issues, it means we may have to start blood pressure treatment. Now, this is just a guide as to how to distinguish between primary and secondary hypertension. So if the diagnosis was made before the child is pubertal, that's before puberty, then it's likely that the cause is secondary. If the diagnosis was made after the child has entered puberty, most likely going to be primary. Also, if it's just the diastolic, which is a lower blood pressure that is very high, or if the blood pressure is particularly high at night, we're likely to be thinking about a secondary hypertension. For children who are obese, most likely primary. Family history cuts across both. And then if there are underlying problems, most likely to be due to secondary hypertension. So this is just to tell us that for those who have primary, usually they don't have any symptoms at all. And for those who have secondary hypertension, they may have some complaints and symptoms. So when we evaluate these children, we need to ask for a history of heart-related issues or kidney problems, or if they've had histories of urinary tract infections or surgeries in the past. The medications we use, like I mentioned earlier, family history, social histories are also very important. And okay, I can skip this. Now, how do we investigate? There are some investigations that are unique that we need to run across all board. We need to look at the urine. We need to look at some chemistry tests to check which will assess the kidneys, the lipid profile, fasting blood sugar to rule out liver issues or diabetes. Then renal ultrasound, that's kidney ultrasound, to ensure that we are not missing any abnormalities. Then we need to do some endocrine screening tests. For those who are snoring, for instance, we may need to do sleep tests. The ECG, which is the electric activity, measurement of the electric activity of the heart, also give a pointer to what the issues might be. Echocardiography is also very important. which is like doing a video of the heart, really to check what's going on around the heart. And that will help us rule out if there are congenital malformations within the heart and what we need to do. Dopplers are also very important, and things like MRI, CT scan to help assess the kidney function. Now, what is the goal, or what are we planning to do when we see a patient with hypertension? If it is essential, which means we can't find a cause for it, usually we need to start on a multidisciplinary approach system, in which case we want to start without using medication at all. So this will involve the doctors, the dietitians, to look at how we can reduce weight when the child is obese or overweight, healthy diet, regular exercise, and of course, reduce or avoidance of smoking. This will be the first approach to see how we can reduce the blood pressure. Now, when we're talking about diet, there's this concept of the dietary approach to stop hypertension, which is this diet that we're looking at and tells us what proportion of fruits, vegetables, grains, fish, legumes, and oil that the child can have. But more importantly, let us know that we need to significantly reduce the amount of salt in the food. Now, when you do lifestyle modification, how does it help in reducing blood pressure? So if we reduce weight alone by about 10 kilograms, it's estimated that the blood pressure can go down to by about 5 to 20 millimeters of mercury. Diet, 8 to 14 millimeters of mercury reduction, reduction in salt, 2 to 8, physical activity, 4 to 9, alcohol consumption reduction. So you can imagine that if you see a child who has primary hypertension and you're able to do all of this, it's more likely that the blood pressure will return to normal. Now, when you've tried all of this and you cannot achieve the aim of reducing the blood pressure, then we need to now use medication. So what are the indications for medication? Severe systemic hypertension, persistent hypertension, patients who are in stage 2, like I've described earlier, and those who particularly have associated kidney issues. And when you start seeing end organ damage, where the heart is affected and the mass, the body, the amount of muscle in the heart has increased because the heart has to pump against resistance, then we may have to start medication. There are so many types of medication we can use, which will range from the ACE inhibitors, ARBs, thiazides, calcium channel blockers, which we won't go into details about. But it's important to know that most children, African children, do not respond very well to ACE inhibitors. So most of them will start them on the calcium channel blockers. So the kind of medications, ACE inhibitors, ARBs, the thiazides, the calcium channel blockers. Now, what is the goal when we are managing children with hypertension? For those who have primary, we want to reduce their blood pressure to lower than the 95th centile. For those who have primary but have other factors that may be associated with them, or those who have even secondary hypertension, we want to reduce to lower than 95th centile with the effects or with the hope that the amount of end organ damage will reduce drastically or will not progress further than where it is already. Now, you have a patient who has been on blood pressure treatment for a while. When do you step down or when do you stop? Because that issue will come up. Some parents will ask you, oh, so my child is hypertensive, is on medication. When are we likely to stop the medication? Well, I guess the first thing to do is to do a trial so that you need to be sure. And the patients who will qualify for that are those with most likely primary hypertension who are well controlled on one single medication. So if the blood pressure is not controlled by, is controlled by more than 2 medications or more than 1 medication, it's not very likely that that child is going to stay off medication except a cause is found and that cause is tackled. So if you have a child who is on one medication and has made significant progress, particularly with the lifestyle changes that we talked about, then we can consider stopping medication for a while and monitor. And if the ongoing lifestyle intervention is working very well, then we can discontinue, but we should realize that we cannot stop monitoring that child. Now, for those who have secondary issues, the major problems are usually heart-related or kidney-related. Then we need to correct whatever those issues are. So this is, for instance, the case of coarctation, where you have narrowing of the vessels from the heart, that's the aorta, and there's this obstruction. So you need to do something to relieve this obstruction to make sure that the blood pressure, that the blood flows very well. The other question you be asked is, can my child participate in sports? So that's a tough one to manage. But of course, we have to work with the parents to determine what kind of sports that child can engage in. So if you have a patient with stage 1 high blood pressure, we've evaluated, we can't find any end organ damage, the heart is functioning very well, the kidneys are okay. Yes, you can say participate in any sport that you like, of course, with monitoring. But when you have patients who are in stage 2 hypertension, then, and of course, even if there's no evidence of organ damage, because it's the stress on the heart, you want to reduce or restrict them from performing some sports, which will classify as class 3A to C, which we'll see in the next slide. So for those who have very high blood pressures, we'll tell them to avoid things like this: gymnastics, rock climbing, which we don't see a lot of, weightlifting, wrestling, boxing, but all the other low energy sports, they obviously should be able to participate in. Now, what is the take-home message for high blood pressure in children? Is that, one, we need to have the skill to measure blood pressures properly, because the greatest disservice is to label a child as being hypertensive when in actual fact they are not. And of course, we also need to have the appropriate charts to measure the percentiles, agree the percentiles, and determine whether they are hypertensive or not. We also need to identify that there is some group of children who are at risk population and deserve early surveillance. We need to rule out kidney and heart-related problems. And let us realize that the goal differs between primary and secondary hypertension. So that's my talk on hypertension. Then we'll quickly go into diabetes, and then we can proceed to question and answers. I saw this quote, and it was for me very interesting, that if you skew the endocrine system, you lose the pathway to self. And I've reflected on this over and over. Of course, anytime there's a problem with the endocrine system, there's a problem with the patient ultimately. So let me share a case I was called by a friend to look at about 3-4 weeks ago. So this 4-year-old girl presented in the clinic. Please note, I'm saying 4-year-old with a weight of 30 kilograms, pulse of 102 beats per minute, and the SpO2 of 97. And the major complaints were this child was urinating more frequently. The parents noticed urinating more frequently in the last 2 weeks. A child that was initially dry at night now urinates more than 4 times, and of course even more during the day. Now bedwets, and they have to wear pampers or diapers for the child at night. And then they notice a rash around the pubic region. So the young doctor who saw the child in the clinic, as part of the initial investigation, decided, oh, since he's urinating more frequently, let me check the urine. Glucose 3 pluses, ketones 2 plus, random blood sugar 370 milligrams per deciliter, no family history of diabetes. The parents were alarmed when the diagnosis was made that this child is not only diabetic, but now is in what we call diabetic ketoacidosis, which is an emergency. So the child had to be admitted and properly managed. So diabetes is a syndrome. It's a syndrome characterized by a disturbance of metabolism of carbohydrate, protein, and fat. We used to think initially that it was just a problem with just carbohydrates, but we now know that, of course, protein and fat metabolism is also affected. And it's as a result of either, number one, insulin insufficiency, which we see in type 1 diabetes, or relative insulin deficiency or resistance, which we also see in type 2 diabetes. Now, it is the commonest endocrine or metabolic problem in children and adolescents, and it can occur at any age. We've seen newborns who are diabetics. Normal blood sugar values, most people will be less than 100 milligrams per DL. Between 100 and 125 pre-diabetes. So we're a bit worried about patients we see at this level, and we want to also screen for other issues. But any reading above 126 milligrams per DL will be classified as diabetic, which is similar to, so if I'm seeing a child who had some symptoms, which I will describe later on, and then we measure the blood sugar level at any time, say the child is coming into the clinic for the first time and is above 200, like we saw in this child that I just described, definitely we need to start thinking seriously. Or we do a fasting blood sugar, which is after the patient has fasted for at least 8 hours, between 8 and 12 hours, and the blood sugar level is above 126, then we need to consider the diagnosis of diabetes. The other thing is, if we do a loading glucose level or glucose tolerance test, as we described, if it's also above 200 milligrams per DL, particularly by the second hour, when we'll expect that the blood sugar level should have gone down, then we should be thinking about. And for those we monitor, when the HbA1c is higher than 6%, then we should think seriously about diabetes. Just similar to what I've just described. Diabetes has been around since time immemorial. It's been described as early as the 5th and the 6th century before Christ. But more importantly, the recent breakthroughs were in 1776 when Dodson confirmed that the taste is due to excess of sugar. And in 1889, Oscar and Joseph discovered the role of the pancreas when they removed the pancreas in a dog, and the dog ended up being diabetic. But then the revolution really was in the 1920s when Banting and Best developed the insulin therapy. That's when they discovered that insulin was the major problem in causing diabetes. So, and that won them a Nobel Prize. Now, Banting was a doctor and Best was a medical student. So you can imagine that the collaboration between a doctor and medical student got them a Nobel Prize. Here's a picture of Banting and Best. When I was looking at the literature, I came across this picture that was quite striking. That after Banting and Best gave the first shot of insulin to this child that we can see on the left, 32 days after, look at the remarkable difference. A child that was obviously wasted with insulin therapy has gained a bit of weight and is looking much, much healthier than he was before the insulin therapy started. So that, of course, tells us the revolution in terms of insulin therapy. Type 1 diabetes, which is the commonest type of diabetes in children, seen in about 90% of the cases, is as a result of the body's immune system destroying the pancreas itself, which is where the insulin is produced. And in type 2, commoner in adults and adolescents, is when the body is less responsive to insulin. Now, what are the clinical characteristics that we can see in this class of children, type 1, type 2? And then we have the monogenic classification, which are children seen usually in young adults, these are usually young adults, and they have what we call maturity onset diabetes of the young. Now, in terms of genetics, types 1 and types 1 and 2 usually have more than one genetic factor, but in the monogenic is usually one genetic factor that can be identified. Age of onset, type 1, younger children, and you have two peaks, usually first about between the age of 5 and 6 years, and then the second peak is just as they're entering puberty. But if the diagnosis is made when they've started puberty or later in puberty, then it's usually likely to be type 2. The clinical presentation for type 1 is usually very rapid and acute, like the case I presented, whereas for types 2 and monogenic is variable, slow, autoimmunity in type 1, ketoacidosis, commoner in type 1, extremely high blood sugar levels, commoner in type 1. Type 1 also, you see a lot more, obesity is commoner in types 2. Acanthosis nigricans is commoner in type 2. Then the frequency, type 1 is the commonest type. But we're seeing more cases of children with type 2 because of the high rate of obesity. And when the parents are diabetics, it's likely to see patients who fall into the category of type 2. So this is acanthosis nigricans, which is a skin condition caused by darkening of the skin around usually the elbow and the neck as a result of, well, the condition, the cause is usually unknown, but if you see a patient with this condition, then screen for diabetes. So the pancreas, which is the organ that makes insulin, is just slightly below the liver. And the way insulin works is that insulin binds to, so for instance, a child that's eating, the blood sugar level has gone up because the food is broken down and glucose is absorbed into the bloodstream. Insulin will bind with these receptors on the cells, which will open up the glucose channel so that glucose goes into the cells and are stored until required. And most of the storage of glucose is in the liver, which is converted to glycogen, and the other cells converted to, particularly muscles, kidney, and fat, is converted into protein, as well as some stored as glycogen and some stored as fat. Now, what happens when there is reduction in insulin or the patient is not responding to insulin? What will happen is that the high blood sugar level, a situation is created where there is high blood sugar level in the blood vessels, whereas the cells are being starved of glucose because there's no glucose to use. So what will then happen is that the body will break down fat and protein. And that's why I said it's a metabolic problem of not only just glucose, but also we have breakdown of fat, which will lead to excess levels of ketones and diabetic ketoacidosis. And for the protein, when you have breakdown of a lot of protein, the patients will obviously be wasted and susceptible to infection. And when there's excess amount of glucose or sugar in the blood system, it overwhelms the kidneys and some of it will spill into the urine. That's why we see a lot of patients who will be passing a lot of urine. This is just to show us what we expect in terms of diabetes all over the world. Now, children account for about 5% of diabetic patients all over the world. But look at this estimate. In 2024, it's estimated about 588 million people who are diabetic all over the world. And by 2050, it's projected that this number will go as high as 850 million. So we're expecting almost a 45 or doubling the rate of 45% increase or almost 50% increase. So within the next 25 years, we're expecting the number of diabetics will double. And where do you get most of these numbers from? The children who will grow into adulthood. Now look at the rate of increase. It's not uniform. In Europe, 10%. North America, about 21%. Look at Africa, where we are, where it's projected that we're anticipating a 142% increase in the number of diabetics. And that's why we need to look at diabetes critically in children. We may think that diabetes is not such a problem, but almost 600 million diabetics around the world. It gives us almost 11% of the adult population is diabetic. Over 1 trillion US dollars was spent in the treatment of diabetes just last year. And that represents about 12% of the global health expenditure. So we can imagine the amount of money spent in management of diabetes. Now, this is Nigeria. What are we seeing? That year 2000, we had less than, let's say, 300,000 diabetics in Nigeria. By year 2024, within a period of, say, 25 years, 300,000 has ballooned to 3 million. That is more than 10% increase, and projected that we'll have more than double that amount by year 2050. This is just showing the same thing in graphical form. The risk factors, family history, genetics, autoimmune problems. Now, there are some environmental factors that have been implicated in triggering diabetes in children. And we're looking more at viral infections, particularly mumps and rubella. And it's therefore important to know that we're seeing patients now, or the country now is trying to immunize children against rubella. So when these vaccines are available to us, particularly in Lagos and other parts of the country, we should encourage our children to take them. Vitamin D deficiency has also been implicated. And then there are some toxins usually found in food stuff or some chemicals that we use at home. And the potential effect is that these environmental factors, for those who are genetically predisposed, will trigger autoimmune responses, which will then damage their kidneys. Nutrition. There's a school of thought that early exposure to cow's milk in the first 6 months may also be a trigger factor. And for some strange reasons, some children who are born by cesarean section have a higher risk of developing diabetes. And those who are, of course, patients of mothers who are diabetic, usually they are large at birth weights of over 4 kilograms and above, we need to screen them. Prevalence all over the world is doubling, higher among the Scandinavians, but then look at Nigeria. The prevalence is about 0.3 over in 1,000. That's what we're talking about, say 3 in 10, 3 in 10,000 children. Whereas you're looking at other countries where you're seeing 15 in 100,000. So we need to worry about this. And it's estimated that some of this as a result of long-term protein energy malnutrition and endemic childhood infections. This is another graph to show us what the number of diabetics. Now, this is looking at children below the green represents children below the age of 20, which will be representative of pediatric age group. The yellow, sorry, my pointer has disappeared. The yellow line shows those between 20 and 59, and then the red line shows those who are above 60. Now, look at this in Africa. If you look at the total number, which is represented here in blue, if you look at the percentage of children compared to adults and the total, and look across the rest of the world, you can see that the prevalence is much, much higher in Africa than other parts of the world for children with diabetes. Now, what has Nigeria contributed in terms of literature to information about diabetes all over the world? There have been a few studies in Nigeria. I will just cite about 4. One is from Kano, which shows a prevalence of 3 per 1,000. which is much higher than what was reported in Port Harcourt and Shagamu. The commonest mode of presentation was diabetes ketoacidosis, which we'll describe later on. Another study that was done in Sokoto, looking at the same prevalence of 1.4 per thousand. The mean age, that's the age at which, the average age at which they presented for those children was 12 years, more female than male. Most of them presented with diabetes ketoacidosis. Another study that was done in Ondo, which now looked at the risk factors, obviously showed clearly that children whose parents were diabetic had a higher risk compared to those who did not. So 38.8 compared to 12.3. Another study is done in Oka, which showed that most of the children had type 1 diabetes, prevalence of about 2 per 100,000, average age between 8 and 18 years, more females also in their own study. 15 children out of the 20, not 15%, sorry, this is a mistake, recovered. 4 were discharged against medical advice and 1 died. But the common thing amongst all of these children is that 95% of them were lost to follow-up. So they never came back after they recovered. Now, we didn't know what has happened, whether they died or they continued their treatment elsewhere. What are the symptoms? Symptoms for children are just similar to those we find in adults. Excessive thirst, excessive hunger, excessive urination, weight loss, fatigue, slow healing of wounds, yeast infections, and blurry eyes. The classic presentation for most children will be passing of excess urine, which we describe as polyuria, drinking a lot of water to replace what is being lost in the urine, which is polydipsia, and extreme hunger, even when food is they will have excess sugar in their system. They are still very hungry because, of course, like a man who is in the middle of an ocean, surrounded by a lot of water, but really not much to drink. Now, presentation is usually very acute, like the case I described, and usually there will be some precipitating factors, either trauma or an infection, or the child is ill from some other things, and then it's at then that they present to clinic and the diagnosis is made. Now, the pediatric emergency like that child had was what we call diabetic ketoacidosis. That was the first presentation for this 4-year-old that I talked about. Usually, most of these children will lose weight, but the case I presented, the child was rather obese rather than weight loss. And the mother told us that, oh, it was a delight to see her children very chubby. So she fed them very well. But then we saw the end result. So they usually present with weight loss, severe dehydration, they're in shock, they're vomiting, they're passing a lot of urine even when they are dehydrated, complain of abdominal pain. Some smell as if they've drunken some wine or so because they have acetone breath. Their breathing is very deep and very rapid, and some of them may be semi-conscious or drowsy. So when we see this kind of presentation in a child that is diabetic, we should know that this is a diabetic emergency. How do we manage? The first point is to say that the longer a patient lives without a diagnosis of diabetes, the worse their health outcomes are likely to be. So the earlier the diagnosis is made and treatment initiated, the better for the patient on the long run. So the pillars of management will follow this pattern: diet and exercise, insulin therapy. For some, particularly those with type 2 diabetes, oral medications. Obviously, glucose monitoring is very important. We have to screen them for complications. And then we need to pay particular attention to families managing these children. They need a lot of behavioral and psychological support because it's not going to be easy to manage a 4-year-old, for instance, who is diabetic, who needs to have insulin maybe 2, 3, 4 times in a day. How do you explain to that 4-year-old that for the rest of his or her life, he or she needs to take insulin and has to inject himself? So a lot of education for the child, particularly the adolescent child, and the families, and a lot of support that will be needed. So blood sugar monitoring, most of us know about the glucometer that we normally use in the clinic to monitor or even at home. Now, for a young child, you may need to do this sometimes up to 6 times in a day, particularly before breakfast, lunch, and dinner, and before they have their afternoon or morning snacks. So if you count that alone, that's about 5 times. And when the children are ill, you may need to do that more often, or when they have low blood sugar levels that you need to correct. But then there's a concept of continuous glucose monitoring where a chip can be placed under the skin, on the skin with some electrodes or needles into the skin that will constantly monitor the blood sugar level. So the child doesn't need to prick him or herself. I will describe this much later on. Now, diet is extremely important. There's no way you can manage a diabetic without diet, without the dietary component of it. And the whole essence of dietary treatment is to ensure that they gain weight at appropriate rates and the growth is optimal, adequate nutrition is provided, blood sugar level is being controlled to as close to normal as possible, other related problems like the lipids, the fat and protein abnormalities are corrected. And all of this is done with the aim of preventing short and long-term complications. We need to involve a dietitian, and the food portions as described above. Carbohydrates will form about 50 to 60% of the calories, protein 10 to 15%, and fat 20 to 35%. The concept of monotonous, old, unripe protein, particularly for the adolescents and the adults, should completely be jettisoned because no person will achieve control on just one diet the whole of their lives, or for the rest of their lives. Exercise is also very, very important because exercise will help in promoting weight reduction and maintenance of the appropriate weight for age. And exercise has been shown to improve sensitivity of insulin. So as they exercise, the amount of insulin you may need may be lower than if they don't exercise at all. But it's important to balance exercise and diet together to each person's health status and fitness. And when the patients are exercising or the children are exercising, we need to tell them about the risk of low blood sugar. Because like we said, if they take the normal level of insulin that they normally use and their blood sugar level goes lower because they are now burning more glucose when they exercise, they may tip them to low blood sugar levels and may become hypoglycemic. Oral medications rarely used, but metformin is the commonest medication that is used for patients with diabetes. Insulin therapy, usually for type 1 diabetics, and most children will fall into this group. Occasionally, you may need to use them in type 2 diabetics when you start treatment to control and then start them on oral medications. But it's important to know that there are various types and combinations of insulin. We have the short-acting, the intermediate-acting, the long-acting. So the type of insulin you use, depending on the age of the child or the sex of the child, well, more likely age of the child will determine whether you're using just short-acting, intermediate, or long-acting, and also how well their diabetes is controlled. This is just a slide showing us the short-acting, the mode of the time of onset of action, peak action duration. So the short-acting, within 10 minutes, you start seeing the effect. Short-acting 30 to 30 minutes, intermediate 30 to 60 minutes, long-acting, and then the duration. So the long-acting dose can be in the system for and remain active for between 20 to almost a day, intermediate 8 to 12 hours, short-acting. So if you are treating a patient with diabetes with just short-acting, it means within 2 to 3 hours, you need to determine whether the blood sugar level is still normal or is within normal limits, or whether you have to inject, you have to give them another dose. Usually there are so many combinations, the multiple daily injections, the mixed forms of diabetes where you have usually a short-acting and a medium or long-term acting combination, and then the recent concept is the use of insulin pumps. And what that does is that the compliance rate is much better. You achieve better glucose control. And of course, it's far safer than if you daily inject yourself. Insulin pump therapy is very useful in preschool children. So imagine this 4-year-old that I described. How do you teach this child to inject herself? It's going to be extremely difficult. But if you have insulin pumps attached to that child, it will definitely help that child in regulating our blood glucose level. It's also very important when we have patients who are athletes, those who fear the needles, and those who have poor control of their diabetes. Right. So when I was a medical student, maybe in my third and fourth year in medical school and fifth year, some 30-something years ago, this was the only method by which we were able to inject insulin to our patients. But after I left medical school and a few years after, we had the concept of the pen, which will be able to calculate the dose and is a bit more accurate than using the needle and syringe. Now, this is the insulin pump. So what happens is that you have this electrode that injects, that's the pump. So you determine how much insulin is needed, is calibrated, and is injected under the skin. Now, there's this automated insulin delivery system, which has been shown in adults to be very, very effective, and even adolescents, children, and some young children as well. So what happens here is that there's a chip that monitors the blood sugar level. That's a continuous glucose monitoring. So let's give an example. This child has just eaten. The blood sugar level naturally will go up as expected. The monitor here would sample the blood level of glucose and then, of course, sends it to the computer in the insulin pump. And that then determines the amount of insulin that it will ask the pump to deliver to the child. So that means continuously you have the blood glucose level being monitored. If it is high, the monitor tells the pump it's time to give a little dose of insulin so that you have an effective control over the blood sugar level. Also very important to know that there are other routes of administration that has been tested, but the most effective so far in terms of data is inhalation of insulin. So it's important that we watch this space. This may just be the mode of delivery of insulin with time if this works out very well. So for the older child particularly, or even for parents, we need to tell them what to do in terms of glucose monitoring, effective weight monitoring, foot care because of patients who may develop what we call a diabetic foot. And as they grow into adulthood, that's very important because we see a lot of adults who have amputation because they've not cared for their feet, personal hygiene, healthy diet, and physical activity. This is a group that we need to pay particular attention to. There's adolescents, because I'm sure most of us know how rebellious we were when we became adolescents. So for an adolescent who is diabetic, we need to pay particular attention to, extra attention to their care, partly because the hormonal changes that occur during puberty tends to affect the response to insulin. So sometimes they may need higher doses of insulin than before. And then the lifestyle that they live, the erratic schedules, they concern about body image, so they don't want to eat much because they want to remain slim. That will put pressure on the amount of insulin they may require. Of course, experimentation with alcohol, and the fact that sometimes they're just completely rebellious and don't want to follow instructions. So we need a lot of counseling and support for the adolescents. Now, when they come for follow-up examination, so we're seeing a child who is diabetic, we're monitoring them. Things we need to watch out for: growth failure, weight gain, puberty, changes that happens to the skin, oral hygiene. We need to look at their eyes from time to time to be sure that they don't have cataracts or the effect of retinopathy. That's when the blood supply to the eyes are also compromised. signs of callus on the legs, which may show that they are not taking adequate care of their legs, blood pressure monitoring, and then, of course, we need to find out about endocrine issues other endocrine issues that they may have. Now, we're rounding up. Acute complications will be those of extreme low blood sugar level, which is hypoglycemia, and then the diabetic ketoacidosis, like I described earlier. So hypoglycemia, which basically just shows that the blood levels are low, usually lower than 70 milligrams per DL. And that can arise when they take either too much insulin, either intentionally or unintentionally, particularly if their eyesight is affected and they don't read the blood glucose monitors very well. When they eat less amount of food that should have been as against what was apportioned before the insulin is administered, or if they administer the insulin and then they skip or delay their meals, or if they've been involved in a lot of physical activities, particularly exercise, or sometimes when they are ill, the blood sugar levels can go lower down because they may not be consuming as much as they should. Now, what are the symptoms? So if you see a diabetic, for instance, who suddenly becomes extremely agitated, asking for a lot of water, feeling very dizzy, sweating, very anxious, and you check the pulse and you can see that the pulse rate is very high, most likely that this child has hypoglycemia and you need to correct by giving glucose. So one of the things you could do is, if the child is still able to drink, just offer a glucose drink. That helps to quickly raise the glucose level. And then you'll see that most of these symptoms will resolve. But for a few of them, you have to give the glucose intravenously. And thereafter, we need to monitor their glucose levels regularly. Diabetic ketoacidosis, like I've described earlier, this is a much more serious complication, which ordinarily will be managed in the hospital. And the management here involves so many things and so many people. Fluid therapy, insulin therapy, electrolyte correction, monitor that they don't have excess fluid, particularly in the brain, that now cause a lot of seizures. So this is kind of treatment you don't give in a small regular clinic. So the patient has to be properly admitted in a clinic where you have virtually ICU parameters, where you have ICU facilities to monitor the parameters and manage the patients very well. For the older child, these are some of the chronic complications that we see as a result of blood vessel damage caused by diabetes. So we have issues with the eyes, kidney failure, diabetic foot, stroke as a result of damage to the blood vessels of the brain, the heart, damage to blood vessels of the heart, which may lead to heart damage and strokes and hypertension. Now, in concluding, one is that the incidence of diabetes, particularly type 1, is on the increase. Polyuria, that's drinking too much water, passing much more urine, eating a lot of food even when they're losing weight, usually are the common presenting complaints. Type 1 is commoner in about 90% of the children. Insulin still remains the main stay of therapy. And the goal in managing diabetic patients is to normalize their blood glucose level to as normal as possible. And we want to reduce their HbA1c to less than 6%. And in all of it, we want to avoid short-term and long-term complications. So thank you very much. This is my presentation. And I want to acknowledge a few people that have helped in preparing some of these slides, particularly Dr. Peter Egoche, a consultant pediatric cardiologist, my team from the Pediatric Association of Nigeria. Also want to thank EHA Clinics for giving me this opportunity to make this presentation. And I'm saying that if you need some of these references, please contact me and I will send them to you. Thank you very much.
Thank you.
Over to you.
Thank you, Dr. Eletu. You should drink some water now because you know.
Thank
Thank
you.
you. So that was a very, very sharp delivery, very extensive. And I thought the slides would be too much, but then I saw why it had to be that much. It's quite an extensive area of cover. And just like you said, when we were doing the check-ins yesterday, it would have been great to maybe separate the topics into two separate events and delve into each one, giving it its merit. But all the same, I think you did a very, very good job. In fact, comments and questions already were coming up while you were still speaking, you know. So let me see if I can get through to some of them. I think one of the people who asked said, is there a way to reverse? He said, please, um, sorry. Thank you for the wonderful presentation. Please, what is the treatment for white coat hypertension? And in situations where the blood pressure was at stage 2 or above when reviewed, what do you do? I hope you got that, sir. You said, what is the treatment for white coat hypertension? And
Yes,
then
and then stage 2.
situations, yeah.
Okay, so let me quickly answer that. So for white coat hypertension, which we describe as blood pressure being higher in the clinic setting as opposed to when the patient is at home, we need to just verify that this is actually hypertension, not because the patient is anxious when they come into the clinic and when we check their blood pressure over a period of time, it's high. So the way to evaluate that kind of patient is to say, over a period of 1 week, 2 weeks, regularly check their blood pressure at different times and have a fair assessment. But the most effective way is to do what we call a 24-hour ambulatory blood pressure monitoring, in which case we'll attach a blood pressure machine to the arm of the child, since we're talking about children now, and just allow them to go about their normal activities. They go to school, they go and do their sports. When they are sleeping, the machine is monitoring the blood pressure and recording it. And after 24 hours, we get a proper tracing and tells us what the blood pressure of that child is. So that's the best assessment. So if during that assessment, the blood pressure is normal, then we just know that, okay, all we need to do is follow up this child over a longer period of time. But if during the process of doing the 24-hour monitoring, we now realize that the child's blood pressure is high, particularly when they sleep, for instance, because at sleep, we're expecting that all the things that will cause anxiety and all of that will have been removed. Then we now know that, oh, this child is likely to be hypertensive or is hypertensive. And then we'll now want to rule out what are the causes. Are we classifying them as primary or are we classifying them as secondary after we've done all the investigations? And if we can find a cause, then it becomes secondary. If we can't find a cause, then it becomes primary. So for stage 2 tells us clearly that that child is hypertensive, because we're not talking about blood pressures over 140/80, whether under the age of 13 or above the age of 13. That we need to specially investigate and also classify whether it's primary or secondary. Now, if it is primary, like we discussed, we'll try and do the initial things, which is a non-pharmacological without using medication, weight loss, exercise, reduction in alcohol intake and smoking and all of that, particularly for the adolescent and the older child, and monitor them. If we're able to control their blood pressure with that, like we said, we continue that over a period of time, keep monitoring. But if after doing all of that, the blood pressures can still not be controlled, then we have to start some medication. And if we find a secondary cause, for instance, if there are kidney-related issues, then we'll try and, as we're still giving medication, we'll try and sort out what those conditions are. And thereafter, if we're able to eliminate the primary cause, we may start thinking about reducing the medication or stopping. But more importantly, we must continue to monitor those children. I hope that answers that. But type 2 is more likely to be on medication or will be on medication.
Okay. Thank you very much, Dr. Elitu. I have another one. Please let me use this opportunity to respond to those of us who are watching via YouTube. You can drop your questions also on the chat area of YouTube. It's live. It's just that you can't speak directly, but of course you can drop your questions. I'll read it out here. So another question we have is said, "Good morning. Thank you for this platform. Please, is there a possibility of reversing pre-diabetes? If yes, what can be done?"
Okay, so we're talking about pre-diabetes. So for patients who are pre-diabetic, all you need to do is monitor, and then with dietary changes, most likely you'll be able to reverse that. So if I see let's assume I see a 10-year-old who ideally should weigh maybe about 30, 40 kilograms and is weighing 100 kilograms. And we've done his blood sugar over a period of time, classified them as being pre-diabetic. And it tells us that clearly we need to now start lifestyle modifications for this child so as to bring down the blood sugar level as we're bringing down the weight, because the obesity may actually be what is contributing to making that child pre-diabetic and possibly tipping them into diabetes. So all the lifestyle changes that we talked about in terms of diet, exercise becomes very important. And we may be able to put them back in their normal blood sugar level range. But even when we've done that, we must continue to monitor them. Thank you.
Okay, thank you, sir. So let me see if we have another one. Okay, so while I get ready to read another one, please, there's a feedback link. There's a feedback survey request, please, because we continually want to seek to improve our webinars. We have that feedback. Can you kindly look into it? I'm also looking at YouTube. I don't have a question there yet. Now, this particular one is saying, how do we do a sleep test?
Well, there are specific labs that are designed for that. And so it's not something we just go into a hospital and say we want to do a sleep test. There are specifically designed labs where the patient is in a home environment, similar to a home environment. And then whilst they're sleeping, they are connected to all sorts of things to monitor different things. So if we're thinking about sleep apnea for a sleep test for somebody who is who has obstruction, say adenoids in a child, for instance. Of course, there are so many parameters we monitor. We can also do sleep tests for patients who are epileptics, in which case you want to see what the readings are when they sleep. So there are so many things we do, but the important is that there are separate labs that are designed specifically for sleep tests, depending on the kind of tests or the kind of diagnosis you have and what you're trying to achieve.
Okay, thank you, sir. Agatha, are you there to take the next question? Okay. He said, thank you, sir. In a situation where the patient is not symptomatic, fasting blood done at several intervals where we're within normal, but the glycosylated hemoglobin is elevated, how do you treat such patients? He said, markedly elevated.
Well, that's going to be a bit difficult to understand, because why I'm saying that is that if you understand the principle of glycosylated hemoglobin, if you look at that principle, then it's going to be extremely difficult for that child to have normal glucose all the while, and then the glycosylated hemoglobin is elevated. Because what happens is that the red blood cell, glucose is bound to the red blood cell, and that binding can be there for quite a long time. So that's why when you do that test, you are looking at a period of the last 3 months. What has happened to the blood glucose level of that patient over, say, the last 3 months? So if the blood sugar level of that patient has been normal, then you expect the glycosylated hemoglobin level to also be normal. But if it's been abnormal all this while, and if it then comes to you to the clinic today, for instance, and the blood sugar level is normal now, if we do the glycosylated hemoglobin level, it will be high. So that's why I say it's going to be extremely difficult for you to have a situation where the blood glucose level has been normal over a long period of time, and then the glycosylated hemoglobin level is extremely high. So there are two variables that don't tend to agree. But if you tell me that the blood sugar level over a short period, say in the last 1 week or even last 1 month has been normal, but then that patient is diabetic and has had a poor control, if I do the glycosylated hemoglobin level, it will be high.
Okay, Doctor. So I seem not to have any other questions. Are there people who want to ask questions live? If you want to ask the question live, you didn't type it, but you want to have the opportunity to ask the question live, I could give opportunity for another one or two. Doctor will still oblige us. Anybody, you want to ask a question? You could raise your hand, click on the raise your hand. I'll unmute you so that you'll be able to speak. Okay, so I have someone's hand up. Sorry, that is Bridget Enriquetola. All right, please go ahead, Bridget. You're welcome. Can you unmute from your end?
How can my boss ask me questions?
Oh, you are the teacher today. Can you unmute from your end? Yes,
Can you
please.
hear me?
Yes, now. I
Good
can hear you.
morning. Good morning, Professor Eletu.
My boss, good morning.
Good morning. Good morning. Now, quick one. My question is concerning nutrition. This GMO they're talking about. Do you think we should be concerned about it in children, the nutrition, and over time, could this also affect diabetes in children?
Okay, thank you very much. It's a very controversial issue, so it's going to be extremely difficult to say whether or not GMOs are good, because it depends on where you are. There are some who will tell you that GMOs are the best thing that has happened in terms of nutrition, whereas other people will tell you, well, we need to be very, very wary because we are doing some genetic modifications of the food items you are giving, and they may end up being passed into our gene directly or indirectly as we eat this food. So I think we still need to do more studies. I'm not aware of any study that has shown that GMO-related products are harmful, but we also then need to know that the fact that we don't have studies to show that doesn't mean they may be good until further studies are done. I think we need to, but if you ask me personally, I will say eat food that God has given to you, which is natural food, not adulterated. Not because I'm against GMOs, but I'm just saying if God has made this food available to you in the form that He has given it to you, I think that's the best thing we should eat. But where later on, if studies show us that GMO foods are very, very safe and they don't have any side effects, then of course, why not?
Yeah. Also, I was also even concerned because of the autoimmune aspect.
Yes, especially that's true.
Because we
because
don't
of the
know
modifications. That's very true.
That could trigger the autoimmune.
Yes, particularly for
challenges.
those who already have some
Type
genetic
1.
susceptibility.
Exactly.
Yeah,
Exactly.
so that's also very important. Yeah.
Exactly. Thank you.
See why you are my boss.
I know. Thank you. Thank you.
Thank you very much.
Well done, sir. Well done.
Thank you. Thank you for that question. I think it was very, very important too. And okay, so I have so I think two questions. So there's a Catherine who's asking. So my question, in underserved communities where routine pediatric screening is limited, what community-based strategies have proven most effective for early detection and ongoing monitoring of childhood hypertension and diabetes?
Okay. Well, the important thing is when the children go to the clinic, I think it deals on all of us who are practitioners to usually assess these children. And when we think or realize that there are some features that we are not happy with, we probably should screen them. 3 years, like we said, is the earliest time we can start screening healthy, normal children. So if they come in for routine check, say they even come in for their vaccination, for instance, nothing stops us from measuring the blood pressure, provided we have the appropriate cuff for their age and their weight. And if it's normal, then once a year we do that. For diabetes, except they present to us or there is a family history to suggest why we should screen them early, it's not very likely that we'll see a child and we just want to say, okay, bring your arm, I want to do a test. But if, for instance, we're managing them for other things, so a child is very ill and it needs to be admitted, that may be a good opportunity for us to screen them for diabetes by doing their blood glucose level as we're drawing blood for other things, maybe full blood count to rule out infection and all the other things. So that may be a good opportunity for us to do that. But the other thing we could also do, which is also very useful, particularly in the rural area, is to check their urine. So a child comes to us in the clinic. We don't want to do any invasive test by pricking their fingers, and just a simple urine test with a strip will tell you if that child is diabetic. And from there, you can obviously pick up other signs and you can do other things. Like this child that I presented, the 4-year-old, just came for because the parents thought she was urinating more frequently than necessary, and the child was already dry, and so it suddenly became wet at night. And the first doctor that saw just said, okay, let me do a urine test, and then we saw 3 pluses of glucose, 2 pluses of ketones, and then went to do a blood sugar test, which was over 300. So the basic things we could do for routine tests when they come to the clinic, for simple things we could do, just urine strip tests, confirm or rule out diabetes. Once in a year, check their blood pressures when they come for their routine tests as well. That's what will, at least those two will definitely help us assess the status of the children concerning hypertension and diabetes. Over.
Yes, doctor, thank you. It looks like I don't know whether the question session is eliciting more questions. So let me just.
That's expected.
Right. Okay, so this one may be something more related to nutrition. So I have a concern about the Milo we use to make tea for children. So what's the healthy alternative we can use? Milo has high sugar content. This is from Nafisa. So did you get that, sir?
Yeah, I did. I mean, in terms of beverages, of course, what we need to worry about is the amount of beverages that they consume. And not just beverages, even things like sugary drinks, Coca-Cola, Ribena, and the things we give them. They all contain quite a high concentration of carbohydrates in terms of glucose. So we need to monitor and ensure that we don't overindulge the children. You see quite a lot of parents, when the children are going to school, the bag is packed with all sorts of drinks. And when you look at it in terms of the amount of calories they are taking, it's quite high. And it's worse when they don't then exercise and when they don't also then eat natural food, because what we're then basically feeding them is over processed food in terms of snacks and drinks. So their blood sugar level is going to go up. I see the most dangerous part of this is that the body has a way of adapting to blood sugar. So if you give a child, let's use Coca-Cola, for instance, or Coke, or any cola, let me not say Coca-Cola because it will appear as if I'm antagonistic. So any cola, for instance, that has high blood sugar level, or any drink that has high blood sugar content, the sugar level will go up. The body will adjust by secreting insulin as expected. And then the sugar level after a while will crash and that child will crave for the next, because when the blood sugar level is now low, there will be a craving for the next drink. And after a while, that child develops a craving all the time for drinks. And that's where the addiction to colas, for instance, will come. So apart from the caffeine that is also there. So it's important that we regulate the amount of sugary drinks we give to our children, and also the amount of over-refined carbohydrates that we also give to them.
Okay, so permit me to ask the final one. So this person is asking Fumilayo on Nakoya, how and when does high glucose levels affect the leg in such a way that their leg, right or left, is amputated?
Okay. Yeah, so these side effects of chronic complications of diabetes, what happens with diabetics is that the blood vessels are affected by so many factors, and the nerves are also damaged because of the high glucose content over a long period of time. So if you have a diabetic, for instance, whose blood flow to the leg has reduced, who has also lost sensation because of the nerve damage to that leg, the patient is not very likely to feel any pain. So if he has an injury or has a needle prick, for instance, he won't know that there's something has happened to him because he has no feeling in that leg. And the injury, so if he doesn't care for his feet regularly to check, he won't know until it becomes extremely dangerous that a big ulcer may develop, or the blood supply has become so bad that the leg cannot be salvaged anymore. And that's why they may have amputation. And there are studies in the adult population that have shown that diabetic foot accounts for almost about 20% of the first presentations that the patients will, first presentations when they come to hospital. So a lot of them is when they have an injury in the leg and somebody says, have you looked at your feet? And then they say, oh, there's an ulcer there, let me go to hospital. That may be the first time they are diagnosed as being diabetic. So that's why foot examination and foot care is extremely important in any diabetic, be them adults or children. Because once they have that, is a slippery slope that if care is not taken, the end result may just be amputation. So it's as a result of damage to the blood vessels as well as damage to the nerves, so that they don't lose feelings and there isn't adequate blood flow to even repair whatever damage that has happened to as a result of injury to the feet.
Oh, wow. There's so much to say from this topic, but I really like the way you've handled this, Prof. Thank you so much, Dr. Lasende, for this very exciting time. Thank you for the questions. Thank you for doing justice to it. I think we have looked through all the questions and in the question area. Yes, I think we have answered all.
There's an, somebody raised, okay, it's dropped.
Yeah, Fumilayo, do you want to speak? I saw the hand, it came down again. Do you still want to speak? I can give you that chance. Okay, somebody is giving feedback. It's a wonderful webinar. Please, can we have more of you doing this webinar? Okay. Okay.
Ever ready when called upon.
All right. Fumilayo, yes, please click on from your end. I would allow you to speak. Please go ahead, Fumilayo. Hello, Fumi. I think you just need to push the microphone from your end. I'll get a signal from this side, then I can click to allow you to speak. Maybe the network too is giving issues. But there's a lot of positive feedback, doctor, to in fact, somebody said even as a pharmacist, she has learned a lot. Very
much.
webinar. So I think the feedback is very, very great, doctor. Thank you so much. We're glad.
Thank you all.
For the great delivery. Unfortunately, I'm not getting Fumi to be able to push to talk
To
from her
speak.
area. Yes. But so ladies and gentlemen, thank you for attending this webinar. Please, if you look at the chat area, I've been dropping a link for feedback. I'll be glad if you can help us respond to the feedback. I've just dropped it. And then if you have any inquiries or so in that feedback link is also a question where you can suggest topics that you want us to look into, and then we'll see if we can get the likes of Dr. Laseyinde or his recommendations to come speak to us on such topics, but we'll be glad to have you. So I'm dropping a link there that you can easily reach us. It's just academy@eha.ng. If you send an email to us, I'll receive it, and then we'll see how academy@eha.ng. So if you also registered for this webinar, you'll have the privilege to receive this recording and also the slides and the certificate of attendance. Since you've registered, it means that we have your email details and we can reach you through that. So once again, Doctor, thank you for taking out time from your busy schedule to give us this full dose, this heavy.
Thank you very much. My pleasure.
Really appreciate you and appreciate your time. So, ladies and gentlemen, until we have the privilege to have another, Fumi's hand is now up again. And because I've promised you, let me allow. It went down again. What's going on? So I guess it's network issue. She's making efforts, but let me see what I can do. Okay, the hand is up now. Yeah, Fumi. So can you unmute from your end? Fuminayo, can you unmute from your end? Okay, so we'll just have to close now, unfortunately. Maybe you can, through the email I've sent, you can send your question and I can.
Hello. Hello.
Hi.
Yeah, thank you. I've been trying to log in to call. Yeah, please, I want to get clarity on the aspect of there was a scenario I had. I'm a medical lab scientist. I had a scenario of someone that did a misdiagnosis. And the leg of one of the person was, maybe the right leg was amputated. And when they went back, they later find out that the person was not responding to treatment. And they got to they now did another analysis. Somebody was telling the story. So I didn't get that clearly. So they now had to amputate the second leg again. Please, I want you as doctor to kindly explain what could have happened, both maybe how you understand what I'm trying to say. So the person was supposed to write, maybe they said left, rose right, and all that. So please, can you help me throw more light to that from the analysis reporting to the leg they will amputate and all that? Please, I want clarity, sir. Thank you. You've been
Okay.
so awesome in your lecture, sir.
Okay, thank you. I think I got the gist. So what we are saying is that this is a patient who presented to the hospital.
Yes.
So he's a diabetic, probably has a diabetic foot that obviously needs amputation. And
Yes.
the wrong foot was amputated. And then came back again. That's a very serious medical issue, malpractice issue, if you ask me. Because for so many reasons. One will be that it will be so glaring when you examine that patient on the table, which leg has a diabetic foot or not. Because usually that leg will have been gangrenous, and just physical examination will tell you, oh, we're supposed to amputate the right leg rather than the left leg. And why it's also very important is that there will have been tests done, particularly a Doppler test, which will show you which leg the blood is not flowing very well that requires that amputation. And then there are other members of the team, because I don't imagine that it will just be one surgeon somewhere or one doctor somewhere who will be the anesthetist, the same person who will be the scrub nurse, and just decides to go and I know that mistakes can happen, but for something as serious as a diabetic foot, I mean, it may be, if there are other reasons, yes, I can understand where errors may be made, but for something as important as a diabetic foot that you have to amputate the leg, then it will be extremely serious for you to amputate the wrong leg and then go back to amputate the leg that was diseased. So there are so many errors. And that's why these days, I mean, even before the surgery, before the patient gets to they will have put a mark on which leg or which limb to amputate so that you reduce the risk of such medical errors. But this to me seems to be a bit pretty serious. Except, of course, we're not talking about a diabetic foot, because if it's a diabetic foot, it will be so obvious. I mean, how do you leave the right leg and then go and amputate the wrong leg and then go back? That patient obviously has a right to sue both the the medical people concerned as well as the hospital for that kind of error. So what we're basically saying is that we need to pay attention to safety, which was one of the things we talked about, I think, last month or 2 months ago, about safety for our patients. So it's important that, because this is one of the goals for patient safety, we need to, I think it's either goal 5 or goal 6, to be sure that we don't amputate the wrong limb. So we need to pay particular attention. And when we are in a team and the lead surgeon, for instance, I'm just using that word, surgeon, wants to do something, and we as members of that team realize that he's making a mistake or about to make a mistake, we should speak up. We should speak up. And not, he may make a mistake out of, not because he wants to make that mistake, but maybe he has overlooked some things. But if you notice that, then you should speak up so that we can make a correction. This is even more important, particularly in the aviation industry, where the co-pilots are told to speak as clearly and as loudly as possible when they realize that the captain is making an error when they're flying. So the same thing, I think, should apply to us in the medical team. I mean, you don't necessarily have to be a doctor. Even other members can realize that, oh, something is wrong. And I give an example, which I gave during the last presentation. As a student, we had a child that had dehydration, and we were all just wondering what's going on. Blood was taken for electrolyte and urea to be assessed, and usually not now where results can come in 15 minutes. It may take a whole day. And then the medical student made a presentation and said, oh, the child was stooling and vomiting. The mother made ORT, and she used 10 level teaspoons of salt and 1 level teaspoon of sugar. Everybody just paused and said, please repeat that again. The consultant said, please repeat that again. Oh, 10 level teaspoon of salt, 1 level teaspoon of sugar. Why it's supposed to be the other way around. And that was the diagnosis, just because the medical student spoke up. You could have said, well, okay, I'm keeping quiet. We're already managing. And naturally, when the electrolyte and urea result came out, tallied with what she had presented. And that was why the child was having the seizures, apart from the dehydration that he had. So it's extremely important that we speak up. Well, I mean, as a pharmacist, for instance, if a doctor writes a prescription and you think, oh, this looks, you just want to clarify, you're not challenging the authority of the person, but just say, oh, doc, please, can you look at this again? Because I think maybe we're giving too much for this child in terms of this particular drug. And then he may write, oh, sorry, instead of writing 50, he wrote 500, just because of an additional 0. Not because he intended to do that, but if you didn't speak up and the child takes the 500 instead of 50 and comes down with a complication, when there's an issue, you also be called to that panel to say, but you dispensed the medication. So that's, I mean, I'm just saying, so across board, wherever we notice any medical error, in quotes, we should speak up and the corrections will be made and everybody will learn from it. Thank you very much.
Thank you, Doctor, especially on this point that you ended, because I think I would say that I also had a situation where I think my speaking up helped save a situation, but in this case, my own child,
Oh, wow.
I had a child born with tetralogy of Fallot.
Okay.
Right. But then because he had enlarged tonsils, we took him for treatment, and they thought the enlarged tonsils was as a result of maybe an infection or something. So he was given antibiotics, and we came back to the clinic, and the tonsils had not reduced. So they referred us to I think an ENT
Yeah.
surgeon. And then they did the X-rays, did everything. And I think while he was trying to get something to just write and stepped out, thankfully I was there with my wife. He just wanted to finalize that the boy will have to go in for surgery. And my wife was like, "Why don't you tell him?" I say, "It's not important now. That's not what he's treating." She was like, "Well, let's just tell him." So the man observed the tete-a-tete going on between my wife and I and asked, "What's going on?" I said, "Well, doctor, well, there's just something else." He said, "What is it?" I said, "Well, the boy has been diagnosed earlier than now with TOF, tetralogy of Fallot."
Hello.
He said, "Ah, and you didn't say it since." Immediately, he gave us back a letter sending us back to where we were referred from. And when I went back to those doctors, the doctors were like, "So why have you never told us that?" And these doctors have been treating this boy for like 2, 3 years, maybe for any other thing, maybe malaria and all the other child, you know. But I had never really told them that he had this condition. So the doctor told me that had that boy been touched, there's no way he'll come out of it. You know? So I think I learned the lesson very loudly that
Yeah, sure. Let's speak up.
picking up really helps a great deal. It can be the difference between life and death. I
Yeah,
think it's been
absolutely.
a very, very, very interesting webinar. Thank you, Doctor, for
Thank
giving
you
us
so much.
time in this. So,
Thank
ladies
you.
and gentlemen, this brings us to the end of this webinar. So, until we come your way again, please do have a very productive day and life ahead. Thank you, everyone. Bye. Bye-bye, sir.